There will now be an opportunity for silent prayer or meditation. Please be seated. The Secretary will read the order.
Debate on vote number 18, Health Appropriation Bill.
I now invite the Honourable the Minister of Health to the podium to introduce his budget vote. The Honourable Minister.
Honorable House Chairperson, my colleague, the Deputy Minister, Dr. Joe Pasha, my Cabinet colleagues and Deputy Ministers present, Chairperson of the Portfolio Committee on Health, Dr. Lomo, and members of the committee, heads of public entities, honorable members, distinguished guests. It is a privilege to present to you the 2025-26 budget of the National Department of Health and to outline our plans for the new financial year and even beyond. This budget is being presented at a very challenging time in the history of our country, including geopolitical events of recent days. However, I must assert that challenging as the moment is, there is a lot to be excited about. We have three main objectives in this budget. Number one, to lay a strong foundation in preparation for the improvement of public health systems of our country, in preparation for national health insurance. There are people who believe that we have no plans, no inclination to do that. We want them to listen attentively today. Secondly, our objective is to lay a strong foundation and to embark on the journey towards elimination of certain diseases, especially communicable diseases, but not leaving behind non-communicable diseases, as you shall hear. Lastly, to implement serious reforms in the private health sector. Please ignore those who want us to believe that there is nothing to fix there in that particular sector. I'll now start with the issue of health infrastructure. One of the biggest problems that the public health system encountered and was severely criticized for is the health infrastructure. The broadside that the sector received is exemplified by the encounter at Helen Joseph Hospital. The complaints which were lodged with the health ombudsman were 7 in number. 5 of them were dismissed outright, and only 2 were upheld by the health ombudsman. The 5 that were dismissed is about clinical protocols, about clinical competency of the staff, etc. But the 2 that were upheld is the issues of infrastructure and the human resources. And we need to fix those 2. For the record, the following new facilities were completed during the 2024-25 financial year, which ended a few months ago. The Sipeti Hospital in Eastern Cape, Lady Smith Clinic in KwaZulu-Natal, Henning Flay Clinic in Northern Cape, Bucheberg Clinic in Northern Cape, Bangara Clinic also in Northern Cape. Additionally, during the reporting period of 2024-25 financial year, 47 existing clinics and community centers, as well as 45 hospitals, were substantially revitalized, while 403 public health facilities were maintained, repaired, or refurbished. The following new and replacement hospitals are already under construction, representing a significant step in the strengthening the public healthcare system and improving service delivery in provinces. The first one is the Limpopo Central Hospital. As you will know, our country has 10 central or academic hospitals. 1 is in the Eastern Cape, 1 in Free State, 2 in KZN, 2 in Western Cape, and 4 in Gauteng. We are now busy adding the 11th central or academic hospital, which is the Limpopo Central Hospital. It's a flagship hospital for the province and health science faculty of the University of Limpopo. This hospital is now 26% constructed. We are also adding Siloam District Hospital in Vembe, which is a replacement of an aging facility. This hospital is 90% completed. The Tlhabeng Regional Hospital in the Free State is also undergoing significant revitalization. We are at 30%. Bambisana District Hospital in the Eastern Cape, a new hospital in OR Tambo District, is at 82% of construction. The Tulele District Hospital in the Eastern Cape in OR Tambo District is at 50% construction. We are also busy constructing Buphelong Psychiatric Hospital in Northwest. In addition to the hospitals currently under construction, the National Department of Health has prioritized several key hospital projects placed strategically to strengthen South Africa's public health hospital network, particularly in high-demand areas like Gauteng, but also in underserved areas. These include 17 major hospital projects which have been identified for development. They are at various stages of design and development. The biggest of these huge projects are total replacement of 3 major central or academic hospitals that have been existing for years but never built. This is the Dr. George Mukari Academic Hospital under Sefako Makhatu University in Gauteng, the Nelson Mandela Academic Hospital under Hotla Sisulu University in Eastern Cape in Tata, the Victoria Mklengo Hospital, formerly known King Edward VIII Hospital, under the University of KwaZulu-Natal. I have studied there, even though I finished medicine 40 years ago. It was never built. We want to build it now. We wish to add 3 new central hospitals in the provinces where they never existed before. This is Mpumalanga Academic Hospital, Northwest Academic Hospital, and Northern Cape Academic Hospitals. These 3 are still in the very, very early stages of planning. Their entry into the health network will ramp up our academic hospital from 10 to 14. The extreme overcrowding in our public facilities is caused by rapid population and rapid urbanization. Please remember that public health system is utilized by 86% of the population, and you can throw in the mix our neighboring countries. If we do nothing, the demeaning scenes we see often on our TV screens, like pregnant women sleeping on floors and chairs, will unfortunately be the order of the day. We have clear evidence of this in the Eastern Cape with repeated problems which appear on TV at Dorang Ginza Hospital in Gqeberha. Our analysis at Dorang Ginza Hospital, the analysis which was also made by the public protector, and we independently reached similar conclusion that we need to build more additional district hospitals in such areas. Hence, we wish to add a totally new district hospital in strategic and overburdened areas. When Bheki Mlangeni Hospital in Soweto was built, it was meant to relieve Kisani Baragwanath Hospital, and I can tell you today, it was found to be woefully inadequate. For this reason, our systems have placed for us where we must put up new hospital. Number 1, we'll put a new hospital, a new district hospital, Diepsloot, El Dorado Park, Soshanguve, Dobsonville or Meadowlands, and a small settlement called Holomisa. We are also on the verge of total replacement of old mission hospitals like the Elim Hospital, which was a former Presbyterian mission hospital. Furthermore, Chilizini Hospital, also in Toyando in Limpopo, is also totally dilapidated. These 2 hospitals are shovel ready. We are just waiting for funds to come in. We can start anytime because they've been planned over a period of 3 years. 5 new community health centers are also mooted. In Gange, in Kraaifontein, in Kwamakhuta, in Kwatomayana, in Metlekong. We will conclude our program with a totally new psychiatric hospital in Mpumalanga. Mpumalanga is the only province in the country that never had a psychiatric hospital, and we believe this must come to an end. Needless to say, these are substantial projects for which will take several years to plan, design, and construct. We do not necessarily have all the money for this massive infrastructure, but we are speaking to international financial institutions, local financial institutions, and other financiers. These facilities and their placement is not a thumbs up. We are using a digital system called HIPS, or Health Infrastructure Portfolio System. This digital system is GIS, Geographic Information System. It has got district information system, and other information systems that help us with data, that help us to understand and plan the health system. So the places which I've named for new hospitals is not just a thumbs up. It's an electronic system that said, place the hospital here and put so many beds. We do not have any options but to do this planning in this manner. If we do not, we foresee us experiencing the same problem that ESCOM experienced, which led to perennial load shedding caused by a lack of infrastructure planning. That's why we want to start early. Other measures to strengthen the healthcare system, House Chair, apart from our allocated budget of 64 billion, National Treasury added 6.7 billion to try and reverse years of austerity measures which have crippled the public health system. So this year, we are planning to do 4 things with that 6.7 extra billion given by Treasury. Firstly, the hiring of 1,200 doctors, 200 nurses, and 250 other health professionals. This will cost 1.7 billion rand. Secondly, acquiring 1.4 million articles to make public hospital hospitable. This will be beds, mattresses, pressure mattresses, bassinets for babies, and new hospital linen and towels. It will cost 1.3 billion rand. Thirdly, the permanent employment of 27,000 community health workers who have been in the system for close to 2 decades, but hired through NGOs. This will cost 1.4 billion. Lastly, to start a journey to pay accruals which have accumulated over the years because of tough austerity measures. These accruals are in oxygen supply, blood and blood products, laboratory services, medical equipment, and pharmaceutical. And this will cost 3.75 billion to start paying. The figures I've given you have been obtained from what we call option C of our plans. We have put our plans in options A, B, C, depending on the commencement date. And the commencement date depends on at what time does this House finish or this Parliament finish the budget processes so that we can start using this money. Let me come to the second objective, elimination of diseases. Honorable Chair, as I said earlier, this is to do away with certain diseases that are problematic. First on the list is HIV and AIDS. We want to state that we've lived with this disease for many decades. The time has arrived that South Africa must start to envisage life without this disease. And we have got plans to do exactly that. Starting with our 95 project, you know that we are at 96, 79, 94. To reach the middle 95, whereby 95% of HIV positive people are on ARVs, we need 1.1 million people. And we have launched this project on the 25th of February, and we are busy with that project. We have noticed with regret that South Africans like the word collapse. Every time something meets headwinds, it is said to have collapsed. The public health system has collapsed so many times. I'm wondering how many lives it has. Even when Trump pulled out this money, we're told that the world's biggest HIV/AIDS program has collapsed. And I want to inform you that's not going to be allowed to happen, Honorable Chair. Treasury has come to the party. You have asked me in the committee many times. Treasury have allocated 553,528,000 for us to start the process of reversing the going away of Trump. This money consists of 590 million, which goes to provinces, 32 million, which goes to national, and 132 million, which goes to researchers in our universities and research institutions. Because the Bill and Melinda Gates Foundation have given us an offer. They said each one of them can pay 100 million rand for research, provided that our treasury must add 200 for every 100 they've given. This has been accepted. Treasury is going to add 400 million rand. The Bill and Melinda Gates Foundation, together with the Wellcome Trust, together they'll give us 200 million. Yesterday, we have met with researchers and the Medical Research Council to discuss this issue and they are going to issue their own press statement. They will call a press conference about it. Chairperson, as I'm speaking here today, in our quest to end HIV/AIDS, as I'm speaking here in front of you, an announcement is being made in Geneva by the Global Fund. The announcement to the effect that the Global Fund has signed access agreement with Gilead Sciences to procure lenacapavir. As you know, lenacapavir is an injection given every 6 months, twice a year, which prevents HIV and AIDS. We have been offered to be the first country to receive it, and we've signed that. Ladies and gentlemen, we believe this is a turning point in the HIV and AIDS. At the moment, the prevention for condoms and all that, but with lenacapavir, remember that during the studies on this lenacapavir, it was found that it protects young girls 100%, even though with males it's 96%, but with girls it's 100%, meaning everyone who received is protected. Ladies and gentlemen, I wish to present to the House a total budget of 64,807,200,000 for the consideration of this House. Thank you very much.
Thank you, Honourable Minister. The next speaker is the Honourable Sene.
Honourable House Chairperson, honourable members, fellow South Africans, health is the cornerstone of any nation. There can be no meaningful, sustainable development, economic prosperity, nor social cohesion and nation building in a fragmented health system along geographic, class, and racial lines. It is against this background that the ANC-led government has tirelessly sought to transform the health sector as a strategic pillar of socio-economic transformation. The strides we have made over the past 31 years in increasing life expectancy from 54 years to 66.5 years and reducing maternal and child mortality is a measurable impact of the ANC's commitment to the fundamental principles enriched in Section 27 of the Constitution that declares that everyone has the right to have access to healthcare services, including reproductive health care. Nowhere can our quest for tackling the cost of living be clearer than what we strive for in respect of healthcare. Honourable House Chair, the last line of that clause, which affirms reproductive rights, is especially significant in today's global context, where we are witnessing in many parts of the world an increase in conservatism and erosion of the rights and liberties of women, particularly their reproductive rights. We stand in solidarity with these women and affirm that reproductive rights are human rights. Research indicates a correlation between access to reproductive rights and women's socioeconomic empowerment, as well as their ability to pursue education, break the cycle of poverty, and lead independent lives. From this, we are convinced of the firm foundation of motherless and that is underpinned by love, compassion, care, and empathy. Therefore, every girl and woman must have the right to bodily autonomy and must be guaranteed access to comprehensive sexual and reproductive health services, including contraceptives, family planning, and safe abortion services. It is therefore commendable that this budget continues to reaffirm the ANC's commitment to universal access to women's maternal and reproductive health, aligned with Sustainable Development Goal 3.7, which calls for the integration of reproductive health into national strategies. Honourable House Chair, health outcomes are not only shaped by what happens within the walls of our clinics and hospitals, they are also shaped by numerous social determinants of health, including access to decent housing, clean drinking water, adequate sanitation, and a quality education system. The entrenched legacies of apartheid colonialism continue to shape and direct the leitmotif of poverty and inequality in a manner that disproportionately affects Black and poor communities, women in particular. It is for this reason that we welcome the explicit commitment in the annual performance plan and the strategic plan to intersectoral action to address these social determinants, underscoring that health cannot be achieved in isolation from other micro-social goals. Honorable House Chair, we live in a world that is constantly evolving with emerging health threats. The 26 million allocation over the medium term to strengthen the National Institute of NICD for pandemic preparedness will play a critical role in ensuring that we can adequately respond to emerging health threats, thereby preserving lives and reducing the burden of diseases on our healthcare system. Honorable House Chair, we welcome the 13.2 million allocation over medium term to strengthen the capacity of the Mines and Works Compensation Fund. We also note the APP's important targets to establish medical assessment centers in high-burden provinces, as well as to improve cross-border coordination with countries such as Lesotho and Mozambique. These interventions build on the progress we have made with about 1.98 billion paid out to claimants over the last 9 years and 3.32 billion over 25 years. House Chairperson, we continue to grapple with the challenge of communicable and non-communicable diseases. Critical programs such as Love Life, Soul City, and SANAC are essential to HIV and TB responses. Integration with these organizations and sustained funding from all sectors of society must continue to be prioritized. Honorable House Chair, equally important must be our collective effort behind the department as the resilience of our system being tested in the wake of the PEPFAR withdrawal. We must continue to support and work together to mitigate the impact of this funding gap amid efforts to engage various donors, ensuring that we ease public anxiety and uncertainty, affirm that ARVs will continue to be available for all, and counter misinformation and disinformation. We have made significant progress in our HIV response, which has been founded on the principles of Ubuntu and solidarity among some key pillars. Honorable House Chair, tobacco products and e-cigarettes continue to pose a significant risk to public health. The Tobacco Control Bill has a vital role to play as a presentation to our unwavering priority, which remains to reduce harm and safeguard the health of all South Africans, especially the youth who are the primary target of these tobacco and vaping products. Honorable House Chair, the African National Congress supports this budget as a reflection of our commitment to building on and advocating the democratic gains we have secured over the past 31 years of our democracy, in an effort to strengthen our health system and improving health outcomes. This is our unwavering commitment to the ethos of the National Democratic Revolution and the realization of a health, just, and equitable society with universal health coverage. Honorable House Chair, the ANC supports. Ke a leboga.
Thank you, Honourable Member. The next speaker is the Honourable Mutubatse.
No, thanks very much, House Chair. House Chair, as the MK Party, we want to stand here and make an ardent appeal to the Department of Health that we must learn to refrain from giving a story that does not reach an end. And it is for this reason, having made that particular appeal, that as the MK Party, we stand here not only to oppose the budget vote 18, but also to reveal its shortcomings. This budget fails to provide meaningful health care for the people of South Africa. we are being asked to approve a budget of 275.5 billion for health of the 25-26 fiscal year. However, when we account inflation, this budget increases by only 1%. Effectively, it represents cut in real terms, even as the demand continues to grow. District health services receives 28.3 billion, yet the clinics are drowning. The HIV/AIDS grant sits at 24.9 billion, but the PEFA, possibly pulling out, we face about 601,000 more deaths and over 500,000 more infections in the next decade. The NHI indirect grant of 858, yet 79% of the facilities remain non-compliant. This budget is not about progress. This budget is keeping a dying system on life support. Across the provinces, infrastructure projects remain unfinished. What the minister has said here is what I was talking about, being a tantalizing mirage, giving our people hope that we will never reach. And our people know that Limpopo Central Hospital is incomplete despite the 4.2 billion allocated since inception. Siloam Hospital District still stands unfinished, as the minister has said. Zitulele Hospital in the Eastern Cape is crumbling from neglect. Bupilong Psychiatric Hospital remains in shell, while mental health needs rise. Bambisana Hospital is stuck in planning since 2016. Meanwhile, in 2024, 2.8 billion meant for health infrastructure was shifted to disaster relief, but disaster in health remains daily and deadly. Honorable members, let us talk about medicine. Our people know the 2025 APP, the department claims it will keep medicine stockouts at 1%, yet the portfolio committee reports 5.7% of the facilities. And why? Because the department cannot pay suppliers. In KwaZulu-Natal, over 1 million patients went without chronic medication in 2024 because the provincial department failed to pay pharmaceutical suppliers. Across the country, hospitals run out of essential drugs, not because medicines do not exist, but because invoices remain not paid. This is not an accounting issue. It's patients left to die for lack of basic medication. The department's failure comes from poor planning, as the minister has said, and financial mismanagement. The department underspent 1.9 billion in 2023-2024, even while patients lay dying in hospital corridors. 15% underspending in administration, 7% underspending in NHI implementation, 620 million in infrastructure grants went unused while hospitals remain incomplete. This department returns money to Treasury whilst the people of South Africa cannot get care. Let's talk to staffing. The department admits 30,973 health posts remains vacant. Senior medical positions dropped by 12% in 2 years. The APP target for filling funded posts at 95%, but we are stuck at 82%. Let's come to the provinces. In the Eastern Cape, hospitals run out of basic suppliers, water, sanitation remain unreliable. In Free State, Bophelong Clinic closed due to health violations. In Gauteng, there is demanding history, still remains a horror that continues to haunt us to date. In Northern Cape, patients travel over 200 kilometers for simple care, specialist care. In Mpumalanga, facilities lack basic oxygen facilities. In the Western Cape, I spoke to the minister. I'm still awaiting a report regarding the Guguletu Clinic, which is an epitome of apartheid health system in this particular country. But because, as we have been making a call for the minister, that we need to have a nationalized system, we will remain with the queues of our people in these hospitals as early as in the early hours of the morning. Now, let's talk to the NHI illusions. 858 billion has been allocated. 79% of facilities failed, they are still failed compliance. The APP promised 80% facilities would be ideal by 2024, but we still having that 79. Still needs to be checked, still needs to be done, but nothing has happened. We're still having cases that are going on in the courts. We're not moving around the question of making sure that our people get universal health care. We are not ready. We still do not have the National Health Board, as we promised. We should be having it by now, but still we don't have it. Now, we call on this particular institution to move with the necessary speed to make sure that we receive a single system that will treat our people with respect. Honorable Speaker, Honorable Chairperson, in conclusion, medicine is a social science and politics is nothing but medicine at the large scale. But by that standard, this budget is diagnosed as a political failure. And therefore, it is for this reason that as the MK party, we reject this budget. Thank you, Chair.
Thank you, Honourable Member. The next speaker is the Honourable Leroux.
Honourable House Chair, honourable colleagues, as we consider this budget vote and get distracted by spreadsheets and tables, I would like to bring you back to the situation on the ground and reflect carefully about the state of health in South Africa today. Is there anyone in this chamber who will honestly say that you are proud of the current state of our public healthcare system? Is there any one of you who would confidently send your mother or brother or child to a random government hospital or clinic and be sure that they would get the kind of care they need and be treated with kindness and with respect? I have worked as a doctor in the public sector for 25 years, and for the past year as a new MP, have had the privilege of visiting health facilities in Gauteng, Northwest, KwaZulu-Natal, the Eastern and Western Cape as part of my oversight duties. I have never seen nurses and doctors as disillusioned and demotivated, nor have I seen dysfunction spread as widely as it is today. We are not even getting the basics right, and accessing care is often a deeply dehumanizing experience, as described on the News 24 website by Juanita Hunter through the story of Auntie Maggie this week. Honourable Minister, I'm not saying that we don't have many hard-working, caring healthcare workers trying to do their best, but they're swimming against a stream of apathy and unaccountability. Neither am I saying that there aren't pockets of excellence where patients get world-class care, but these pockets are few and far between and unevenly distributed. There is much justified criticism about the inequity in our health system between the public and the private sectors, but I have been struck by the inequity within the public healthcare system, sometimes within the same district. It is remarkable, for example, that 3.85 billion rands was spent on the beautiful, modern, but underutilized Pixley Isakasena Hospital in northern Durban, when residents in southern Durban are served by the old, dilapidated and overrun Prince Masheni Memorial Hospital. What are the underlying causes of the dysfunction in our healthcare system? Well, many are out of the control of the Minister and the Department of Health, such as our fast-growing population and the massive quadruple burden of disease that we have, the historical legacy of inequality, and the fact that budgets over the last few years have not kept up with inflation. And on top of that, we have lost PEPFAR funding, undermining one of the best-performing programs, the ARV program. But by far the biggest challenge we have in public health, public health sector, is not the lack of funding, nor is it the inequity between the private and public sector, as the Minister would have us believe. It is, and these are not my words, but the words of one of our preeminent scientists, Professor Salim Abdul Karim. Firstly, managerial incompetence and poor leadership at all levels of the health system. Secondly, corruption, again a sign of failed leadership and a lack of accountability. And thirdly, the high salary bill yet poor productivity of the public health sector, another sign of ineffective and incompetent management. And when I speak to nurses and doctors trying to survive in the teetering healthcare system, poor management of their facilities is their number one complaint. Time and time again, clinicians who work at the coalface feel that management does not listen to them or respect their expertise. Instead, management regards often behaves as if clinicians are their opponents rather than their greatest resource. I personally saw this played out at Zitulela Hospital with devastating consequences for the community served by that hospital. So, how can we address the healthcare crisis, the service that is in crisis? If you ask the Minister of the National Department of Health, there is a magical silver bullet, that is the NHI. And Honourable Minister, I wish this were true. But NHI is not the only way, nor is it, in the DA's opinion, the best way in which universal healthcare can be achieved. Something we, like you, are determined to reach. And though your aims are noble, most academics, analysts, and ordinary South Africans recognize that the implementation of the NHI legislation by a government health system that is riddled with incompetence, mismanagement, and corruption at every level will be a complete disaster. Not to mention the fact that it will destroy our excellent, yet unaffordable for most, private healthcare sector. The focus of the National Department of implementing NHI, despite widespread concerns and the fact that the NHI is likely to be stuck in litigation for the next 5 to 10 years, is proving to be a harmful and costly distraction. I believe that there are four things that are urgently required. Firstly, and most importantly, the Department of Health must make patient care its #1 priority. Not sometime in the future, but starting today. Why not start by doing something about the dehumanizing queues that we see at hospitals and clinics, and decongesting clinics by finally ensuring that 6-month dispensing of ARVs and other chronic treatment is actually implemented as promised. Leadership positions in the National Department of Health, and all leadership positions must be filled by people with the necessary skills, experience, and ethics. And management must start listening to clinicians on the ground about how services are improved. It is clear when management and clinicians work together, hospitals function much better and patient care improves dramatically. We need to spend the money that we are allocating through the budget carefully and well and fight waste and corruption. And fourthly, instead of demonizing the private healthcare sector, we need to use the capacity and expertise of the private sector to help us achieve good quality universal healthcare for all South Africans. I thank you.
The EFF? Is there a speaker from the EFF? No, it's not obvious. There's no name here. You should have presented us with the honourable member's name. You may continue, Honourable Chirwa.
Greetings to the Commander-in-Chief of the EFF, Julius Sello Malema, the officials, commissars, fighters in the EFF Youth Command. This month marks 12 years of the economic emancipation movement. We take this opportunity to invite all economic freedom in our lifetime, loving South Africans to join us in marking this momentous occasion on the 26th of July at the Rugby Stadium in Khayelitsha. The struggle continues. But today, we confront a different struggle, the survival of our public healthcare system, which this budget once again fails to protect and to build. The Minister has tabled a budget of 296 billion for 2025 and 2026. While it reflects a nominal increase from last year's 277 billion, the rise is far below what is required to address the structural collapse of healthcare infrastructure, to employ the thousands of healthcare workers sitting at home unemployed, and to provide quality healthcare to the poorest South Africans. Moreover, the growth is insufficient in contrast to inflation and the population growth. 46.7 billion over 3 years is allocated to health infrastructure, but there's no clear rural allocation or transparency on its utilization. We have sent a written question to the Minister requesting a list of all health facilities that they claim to have renovated and refurbished over the past 10 years. We know, like you know, that majority of those monies they claim to have fixed our hospitals didn't even make it to the gates of our facilities. We will visit each and every one of them to expose the lies and the corruption. This budget won't result in more and sufficient employment of doctors and nurses that are sitting at home. It won't see any new and mass building of clinics and hospitals. It won't end obstetric violence. It won't absorb and train community healthcare workers at a rapid pace than what the minister presents, and won't be filling vacancies in our hospitals. This budget won't increase mental health support for children and the youth, with only just about 40 child psychiatrists in the whole country, and no plan to increase them, a country with the third highest suicide rate in the continent. This budget won't end the corruption happening in Gauteng that sees the tripling of money spent on security tenders over 2 years, but no betterment of security systems. It is good that General Mkhwanasi finally gave gravitas to our sessions, that we are being ruled by mafias, that the tender system run by the ANC and the DA is a criminal syndicate. This budget will simply go on to maintaining the status quo and finding the lifestyle of comrades and their gangster handlers, whilst our public health sector continues to crumble. This department is a daily witness and refuge for criminals. You deliver pregnancies of 10-year-old children, and you don't call the SAPS to report the rape crimes, as per the recommendations of the CGE. This department cries every day about being overburdened by illegal immigrants, yet not once have they ever called the SAPS and relevant authorities when they come over to your facilities. There's simply no commitment to build the public healthcare sector and have it provide the necessary services to our people. You will then proceed to pretend that you suffer from humanity, when in actual fact, you suffer from incompetence and lack of compassion for our people. To usher quality healthcare, prevention, and education, you must redirect the NHI funding to building more clinics and hospitals in our communities, prioritizing rural areas that stand to benefit nothing from the NHI in its current form, as there's no life and net care that can hide your inefficiencies in provinces like the Eastern Cape. There's no private hospital that you can outsource healthcare from in Kokama, Taung, Msinga, Onsepkans, Nase Balfo. Take those NHI monies that your comrades are already eyeing and employ doctors. You can't just accommodate 1,000 new doctors when over 2,000 are sitting at home unemployed, and your vacancy rate in provinces like the Free State is a staggering 22%. Cancel all tenders for cleaning and security services in public facilities and insource our people. Your comrades have eaten, it is enough. Invest in building state capacity. Increase the allocation for HIV prevention. 75.6 billion is below what is needed to expand PrEP and PEP access. Investing in PEP and PrEP is a direct investment into the future. You are alleviating the financial demands of HIV and AIDS in the future. Start today. Place focus on prevention and education. Cancer, mental health, sexually transmitted diseases, chronic illnesses can be adequately confronted through preventative measures. Prevention is the only way to alleviate the burden on our public healthcare system. And this budget is far from realizing this. We will continue to fight for economic freedom. We will continue to fight for health justice in our lifetime. And until then, this budget is rejected with contempt.
The next speaker is the Honorable Mshlongo. Order, honorable members. Order, honorable members.
Honorable Minister, Honorable Chairperson, fellow South Africans and colleagues, I greet you. Honorable Chairperson, the IFP welcomes the department's increased allocation of 1.7%. However, we remain concerned as the increase is overshadowed by inflationary pressures and growing healthcare demands. In reality, this increase is insufficient for the scale of reform that our country's healthcare system needs. We welcome the department's focus on strengthening financial management, expanding antiretroviral treatment coverage, and accelerating the development of national health insurance accreditation framework. We are particularly concerned about the declining health workforce a 12.1% reduction in headcount, especially in critical senior roles, undermines the very foundation of healthcare delivery. While we acknowledge the allocation, which is intended to increase and create approximately over 1,700 new healthcare posts, this must be accompanied by improved working conditions, targeted recruitment and retention strategy for healthcare professionals. Honorable House Chairperson, we once again want to reiterate that universal healthcare coverage must not come at the cost of quality, accessibility, or service sustainability. Major concerns remain about the readiness of digital health system infrastructure deficits and underperforming indirect grants. Moreover, the potential withdrawal of PEPFAR funding presents a significant threat to South Africa's fight against HIV and AIDS. The IFP urges both the National Treasury and the Department to develop a proactive, well-renounced contingency plan. Failure to do so risks undoing more than 2 decades of progressive in combating the epidemic. Healthcare is not just a policy issue, it is a human right. The people of South Africa deserve a system that works. In light of the matters raised, the IFP supports this budget vote. I thank you.
Thank you, Honourable Member. The next speaker is the Honourable Peters.
Honourable House Chair, honourable members, on behalf of the Patriotic Alliance, we declare our support for Vote 18 for the health budget of 2025-26. We recognize the critical role that a well-funded and efficiently managed health sector plays in ensuring well-being of our nation. However, we do so with a measured optimism, cognizant of the challenges outlined in the Fiscal and Financial Commission's report, which we highlight the constrained fiscal environment and the pressing need for prudent financial management. The Commission's report underscores the difficult economic conditions facing South Africa, including sluggish growth, rising debt, and competing demands on the fiscus. These constraints necessitate greater efficiency, transparency, as well as accountability in health expenditure. While we support this budget, we urge the Minister of Health to ensure that every rand is spent effectively to deliver quality health care to all South Africans, particularly the poor and vulnerable. The recent withdrawal of the US financial assistance in the health sector has created a significant shortfall, particularly in programs related to HIV, AIDS, TB, and primary health care. This development is deeply concerning, and we call upon the National Treasury and the Department of Health to clarify whether sufficient provisions have been made to mitigate this loss. The people of South Africa deserve assurance that life-saving programs will not be compromised due to external funding cuts. The Department of Health's 5-year strategic plan outlines critical priorities, including universal health coverage, improving primary health care, and strengthening the national health insurance framework. We urge the Minister to remain steadfast in overseeing the implementation of these goals, ensuring that political and bureaucratic inefficiencies do not derail progress. A key pillar of a functional health system is proper infrastructure. We note with concern that the deteriorating state of many public health facilities, where broken equipment, leaking roofs, and overcrowding hinder service delivery. The 10-year National Health Infrastructure Plan must prioritize maintenance, refurbishment, and modernization of hospitals and clinics. The Patriotic Alliance supports Vote 18, but with a firm expectation that the Department of Health will exercise discipline, transparency, and unwavering commitment to service delivery. We call on the Minister to ensure budgetary reprioritization, apologies, to cover the US funding shortfall without compromising critical programs, strictly monitor the implementation of the 5-year strategic plan, accelerate infrastructure upgrades under the 10-year plan to improve healthcare conditions. 2, prioritize interest of the South Africans first above any other foreign nationals. And the PA will say, abahambe. The health of our nation is non-negotiable. Let this budget be a stepping stone toward a stronger, more resilient public health system. Thank you.
Thank you, Honourable Member. The next speaker is the Honourable van Staden.
Thank you, House Chairperson. House Chairperson, the question is, what do we do with this budget? Is it business as usual, or are we going to do something with it for a change to make life easier for the South African public? Does the public really care about this debate? Does the public really care where this money is allocated to and to what entity? And does the public really care if we stand here for year after year and debate about this budget? No, they don't. What the public does care and worry about is what hospital they will be admitted to if something happens to them. They do care and they are scared if they are going to receive good treatment or if they're going to leave that hospital with either terrible memories of terrible service or are they perhaps going to leave that hospital, and it's sad to say, in a body bag. Will they land in a state mortuary where they'll be probably stuck for months before a burial can take place? They are worried if they will receive cancer treatment or not, or just be sent home to die. They are worried if they will receive an operation or if they will be stuck for months in a hospital bed to wait endlessly for this operation to take place. They are worried if they will receive medicine after they have been discharged from hospital, and they are worried if they have to stand in endless long queues from 3 o'clock in the morning until late in the day just to be treated by a doctor. When we have doctors that are worried that they will get the necessary medicine and medical equipment to treat the patient. They are worried if the theatre will be operational. They are worried about how many lives will probably be lost due to the little that they have that they must work with. Doctors also worry about the daily conditions that they must work under. Then we have nurses who are also worried about the daily treatment of patients. Will they have enough linen, beds, food and medicine available for the patients? The stress levels of patient doctors and nurses are escalating due to bad service delivery. What do we do? Debate about something that the public, doctors and nurses do not care about at all. They simply want to receive and provide good services to the patients and provide good service delivery. That is it. Nothing more, nothing less. When will we start providing it to them? It must start now, at this very moment, here in Parliament, today. There are many good chapters we can take out of a book from a private sector that we can learn from, but namely world-class standards. But there is also one very good chapter from our own book that we can also learn from. A few months ago, we visited the public hospital in KwaMashu in KwaZulu-Natal. According to me, the best public hospital in the Republic of South Africa, the best run public hospital in this country. Thank you to the management of that hospital for setting new standards in public health and for the good management and service that you are providing there to the citizens of this country. Ons het nie 'n gebrek aan geld nie, maar ons het 'n gebrek aan kundigheid en goeie bestuur. Wanbestuur en korrupsie, dit is wat die openbare gesondheidsorg vernietig het. It is up to us all, it is up to all of us here to do what is right. We owe it to our country. And it's time to put South Africa first. I thank you, House Chairperson.
Thank you, Honourable Member. The next speaker is the Honourable Letlape.
Chair, Honourable Minister, Honourable Deputy Minister, the Chair of the Portfolio Committee, the DG and staff, ke a le dumedisa. Ka Setswana, there's a saying ya gore re na le rona. And what that means is we are with us, not with you. Because when you say you are with you, it means you are just sympathizing. You are not pledging solidarity. Now, I would like to urge the honorable members to support the members' motion that I will put, that all of us should use public services. All the leaders, from president to MPs, to members of the executive, to the DG of health, to all public servants, to judges, all of us that are public servants must use the public services. If we do that, we fix the public healthcare system. We need to amend the Constitution. Section 27 should not talk about everyone. It's not time to be Father Christmas when our people are suffering. It should be specific to citizens. Our hospitals are being overrun by people from elsewhere. You remember Dr. Ramatuba a few years ago. It's time we acted and not pay lip service to what needs to happen. So we need a constitutional change. And as Section SA, we've submitted that those rights must be to citizens. Now, the second issue is that about PARMED and other medical aids. They should be voluntary and optional. It's a violation of the Constitution. Just to read, Human Dignity, Chapter 10. Everyone has inherent dignity and the right to have their dignity respected and protected. We can't be forced to belong to PARMED. Our dignity is being impugned. Chapter 12, subset 2B. I have a right to security in and control over my body. That is in the Constitution. So I put it to you members that those of you that want to stay separate from society and sit in PARMED have a right to do so. Those of us that want to be with the people have a right to do so. Let it be voluntary, let it be optional, so that those of us that have a conscience must live with a conscience. Those of us that want to build this country with the people of this country and be with the people of this country must be able to do so. Minister, you are taking over control of the money through NHI. Please, take control of the services as well. Health has to be a national competence. So that any problems, we need to be able to hold you accountable. Provincialization doesn't work in health. We've had a few provinces under administration. Gauteng would have been gone if it was a company. So, Minister, when we talk about 5.7 billion that comes from Treasury, 1.7 to doctors, it's up to the provinces what they do with that money. We want you to have the authority to ensure that the monies are spent for what they are intended for. Now, you do not have that power. And unless you are given that power, this is wasteful expenditure. This is feeding the trough. This is putting money to the crooks and to the tenderpreneurs. So unless there are constitutional changes, unless there's power to you, Minister, we're wasting time. Unless we pledge solidarity with the people of this country, this money is a waste of the resources of this country. We support you, Minister, but it must
Remember,
be
your time
that
is
we
now
are
expired.
with the people.
Thank you. The next speaker is the Honorable Deputy Minister of Health.
Thank you very much, Honorable Chairperson. Also, let me also greet my colleague, the Minister, Dr. Motsoaledi, the Chair of the Portfolio Committee, Dr. Lomo, and all the members of the committee, members of the National Assembly here present, heads of our entities and leaders of our department. Thank you very much again, Chair, for this opportunity to participate in this debate for the Department of Health. This debate, unfortunately, takes place on a very sad week as we mourn the passing of a long-standing public servant, a public representative, a leader in this House, a former chair of our South African National AIDS Council, our late Deputy President, Honorable Didi Mabuza. We pass our condolence to his family. May his soul rest in eternal peace. Honorable Chair, as we hold this debate on a very important year when we celebrate 70 years of the adoption of a very important document which became a lodestar during our struggle for freedom, but also a base document for our democratic constitution and has remained relevant and of reference as a reference point, namely the Freedom Charter, which turned 70 years of age on the 26th of June this year. The Charter declares on health, I quote, a preventative health scheme shall be run by the state. Free medical care and hospitalization shall be provided for all, with special care for mothers and children. Chairperson, while we acknowledge that a lot still has to be done, we also assert without any fear of contradiction that we have moved a long way in the attainment of these aspirations in terms of increasing access to services and removing barriers. As we said on the 13th of June 2023 on the passing of the National Health Bill then, which is now an act, we said that this was the next serious milestone towards the realization of the Freedom Charter. And we are well on our way to the implementation of this act, despite the various challenges by those who are opposed to equity and transformation. When this act is fully implemented, the aspirations of a preventative health scheme run by the state and free medical care at the point of service as espoused in the Freedom Charter will be fully realized. Honorable Chair, while we must remain focused, as the Minister has indicated, on the elimination of various infectious diseases, key amongst them HIV and AIDS, TB, malaria, various children's infections, waterborne diseases such as cholera, typhoid, we are also wide awake to the fact that non-communicable diseases are a rising menace to our population, as is the case in other countries, both developed and developing. It is for this reason that on the 25th of September this year, the UN General Assembly will convene an unprecedented fourth high-level meeting of heads of states to discuss progress since the third high-level meeting, which was held in 2018 on non-communicable diseases. As you are aware, Honorable Chairperson and members, what we're talking about here is the challenge of high blood pressure and its consequences, diabetes mellitus and various complications of arising, various cancers, especially those afflicting women, mental health challenges, chronic respiratory diseases. Our overall strategy for non-communicable diseases is anchored on the pillars of prevention, early detection, and effective treatment where cure is possible, and retention on treatment and monitoring where it is a lifelong ailment. As many of us are aware, the cornerstone for prevention of this NCDs is managing our lifestyle. One, not smoking, and we hope that you'll support the bill, which is still with yourselves, members. Also, not taking alcohol, or if you do take, make sure it's moderate, eating healthily, diet with high in fiber, vitamins, minerals, and other key ingredients, regular physical exercise. We have partnered with various organizations such as the Park Run, which is led by one of our legendary comrades, marathon multiple winner, Mr. Bruce Fordyce, to use open parks for people of all ages to walk and run. This is done every Saturday morning. In most areas, you can just find out where the park run is. Saturday morning at 8 o'clock, please go and join. And let's get members of society to do so. In as far as regulatory aspect, honorable members, we have amongst the tools, the health promotion levy, which is also called the sugar tax, to make sure that we can reduce the intake of sugar. Also regulations to control trans fats, to reduce salt, and make sure that we consume less than 5 grams of salt per day. In 2023, we published draft regulations to improve food labeling requirements, which clarifies more clearly what is in the content of the food we eat, which is sold. After public comments, we are about to conclude the amended regulations. In as far as early detection, honorable members, we have enrolled a campaign to make sure that early detection in as far as high blood pressure can be rolled out at various levels, including at community level. This campaign aims to strengthen district and community-based responses. so that it can be integrated into our primary health services. I'm happy to report that over the last 5 years, we've been able to reach and even surpass our targets in as far as making sure that millions of people are actually tested. During the 24-25, we managed to conduct a total of over 44 million screenings for both high blood pressure and diabetes. And this is attributed to high increase in uptake, but also reaching out to communities, not only those who come to the health services, but also reaching out to them. For the next 5 years, we also aim to make sure that we can sustain and even go higher by screening over 45 million for both blood pressure and sugar diabetes in the course of a year. Honorable Chair, in terms of prevention of chronic respiratory diseases, as I said earlier, I leave that to the members of this House to make sure that the new tobacco control bill is passed into an act. If you do so, honorable members, you'll be saving millions of lives. In the areas of other menace, which is cancer, according to South African National Cancer Registry, the top 5 leading cancers include breast cancer, prostate and cervical, colorectal, and also lung cancer. Cervical cancer ranks as the second most frequent cancer amongst women in South Africa and the first most frequent cancer among women between the ages of 15 and 44. Of the female cancer cases, the number over the time has been increasing. Now, cervical cancer, honorable members, is unique amongst other cancers in that the causative organism, the causative virus has been clearly identified and vaccine has been developed and therefore can be prevented. And it is for this reason that the WHO is leading member countries in a campaign to eliminate cervical cancer by 2030. Just a few weeks ago, I attended a conference in Indonesia, in Bali, where under the WHO and ourselves, also South Africa, and a number of countries were co-hosts in making sure that we can continue to mobilize for the elimination of cervical cancer. In our country, we have made some significant progress in as far as vaccination. Since 2014, 85 to 89% of targeted girls in grade 5 and 9 have received 1 or more doses. During the February-March 24 round of HPV vaccinations against cervical cancer, over 400 girls in this category have been reached. The program has since been extended to private schools. We started with public schools. The WHO has also made it easier by actually confirming scientifically that we don't need 2 doses, but that 1 dose will be enough. So the WHO Global Strategy to Accelerate Elimination aims to put countries on a path to elimination. We will need to achieve an ambitious goal of reducing to less than 4 per 100,000 in terms of the incidence. We are committed to the elimination of cervical cancer, and we're going to be going forward in terms of the 3 pillars, which is prevention through vaccination, also in terms of making sure that women have access to very effective testing through the HPV testing, screening, and also making sure that they've got access to treatment. Lastly, Honorable Chair, as far as the issue of mental health, we want to just call upon all of us and society to say, we really face a serious avalanche of mental illness, and this is driven by substance abuse. So I think all of government and all of society is called upon to make sure that we can deal with this menace of substance abuse-driven mental illness, especially amongst our young people. I hope we all support this budget vote. Thank you.
Thank you, Deputy Minister. We now invite the Honorable Reverend Meshwe.
House Chairperson, the ACDP rises today with both gratitude and grave concern. We acknowledge the 277 billion rands allocated to health this year, with projections rising to 329 billion by 2027-28. Yet we must ask, Will this funding translate into real, measurable, excellent service for all our people? The ACDP believes government's national health insurance is seriously problematic, the concept of which is already driving skilled professionals abroad. Those expertise and research findings uplift all South Africans. Instead of eroding private healthcare, we must find funding for innovation to expand urban and rural access to healthcare while preserving proven systems. The ProfMed CEO and Health Funders Association chairman sees the solution in collaboration, saying we have seen the potential in shared procurement, skills transfer, and strategic funding models that just need scaling. The ACDP is also troubled by the secretive adoption last month through the silence acquiescence process of the UN to the World Health Organization pandemic agreement, which compels compliance with their directives during future pandemics, potentially undermining democracy and overriding our national laws. It was previously thrown out, but subsequently the revised version was secretly and deceptively pushed to ensure that it bypassed robust national debate and public scrutiny. We reaffirm that any amendments to the international health regulations or the proposed pandemic treaty must be subjected to full parliamentary scrutiny and public consultation. The ACDP demands a debate on this subject and a rejection of this agreement that will potentially rob us of our sovereign rights. Chairperson, we welcome the department's commitment to employ 1,200 doctors and 200 nurses this year. But this is way too few to a crisis that was long in the making. The public health system lost nearly 9,000 workers last year alone. We cannot continue to treat our healthcare workforce as expendable. Tensions that are taking place at government clinics fueled by Operation Dudula's unlawful actions must be disapproved. While the ACDP acknowledges that our constitution guarantees healthcare access to all within our borders, regardless of nationality, we are nevertheless planning to call for a constitutional amendment to Section 27 of the Bill of Rights and to ensure that all our members in South Africa, particularly citizens, get professional and the best healthcare possible. Thank you.
Thank you, Reverend. Honorable members, we now invite the Honorable Nkwankwa.
Siyabulela. Minister, ndifuna uyithetha ngesintu le nto kuqala. Uba uya kwiPilani Clinic NU1 eMdantsane, ufika phana yingxaki esayibona ngosascampaigner, ufumanisa ukuthi kweza container zingaphandle zihlelele abantu abane-HIV and AIDS, abakwazi ukuya kuyo ngenxa ye-stigma attached to it. Zibekwe ecaleni zona nezi futhi zabantwana abacwangcisayo, akho mntana ufuna ukwaziwa kokwabo ngakumbi kwi-context yethu culturally ukuthi ngoku sekulungela ukwabelana ngesondo. Uxolo ungacwangcisi ukuzavela aze nesisu endlini kunobenze loo nto. Nabantu kula clinic nakwezinye ufumanisa ukuthi bahlala phandle, bafola ngaphandle, noba sekubanda kuqhaqhazela na kuba kaloku isakhiwo sincinci. Ndakhe ndanomakazi wam olala eSicily Makhiwane, kwakufuneka ndithwale iingubo njengehabsaka ndiye nazo phaa kuye ukuze kwakungekho zingubo. Siyayamkela ke le nto xa nisithi ngoku kuza imali ezawukwazi ukuthi ithenge izinto ezidingekayo ezibhedlele. Ayisiyonyani ukuthi i-public healthcare yonke iyakolapsa okanye ayisebenzi. Umamam bendimhlisa ndimnyusa ndimsa kwi-private doctors, bebika imbiba bebika ibuzo, uyoncedwa eGrey Hospital eQonce. Yakanti wafumanwa si-stroke elele. Zonke abasamfufu khange bayazi into bebeyenza kutya nje imali yam ndisoloko ndibhatala oko. Ziyasebenza usebenza oko, zidinga nje isikhokelo esirayithi. Okwesibini kule nto minister, sikhona nesinye esesgida phaa eqoboqobo, hayi mntakabawo oko yayikhiwe nguNgoyesizwe, bathi abantu noba balele ngaphakathi bayabona ngaphandle. Ndiqinisekile bakhe bancokole nenyanga ngenxa yesithukuthezi. ziyafuna ulungiswa. Bekhe sathetha nee-healthcare professionals ebezithetha ngale mali ye-PEPFAR nokuthi kuya cross-subsidizwa ngayo, bade bathi abanye bendingayazi noba abasebenzi babebhatalwa ngayo bekwezinye units ngale mali ye-PEPFAR. It means funeka siyiqwalasele ukuthi isenongachaphazeli imicimbi odibenise ne-HIV AIDS kuphela, unochaphazela nabo. Okwesibini, kule nto ye-doctor-patient ratio that is less than 1 doctor per 1,000 in South Africa, uzawufumanisa ukuthi uba nisicaciseli ukuthi nisi-allocate njani ezi figures ukuthi nincedisa mhlawumbi ii-provinces ezine-ratio encinci nezinye kuba abagqirha bayazibaleka kaloku ezi provinces zethu zingena-resources ezirayithi bazohlala kulaa makapa bakhumshe kamnandi apha bangayenzi le nto fanele uyenziwa. Okwesibini, uDeputy President sambuza iquestion eHousini a director about land funding available if you were to looking at wathetha nge-National AIDS Council, which was going to start engaging other emerging global countries, particularly China, in diversifying funding for HIV, AIDS, and TB programs, as indicated on the China Commitment Section 10.1.6 of the Forum on China-Africa Cooperation Beijing Action Plan 2025-2027. It would be great kule nto sinale challenge ukuthi loo nto ihambe njani. Nihleli ningayifuni i-UDM apha. Nkosi.
Ixesha liphelile. Honorable members, we now call upon the Honorable Zibi.
Thank you, Honorable House Chair. Let me recognize fellow members of the House, the Minister and Deputy Minister. But I also want to recognize and salute public healthcare workers all over the country who work under challenging circumstances sometimes. Dr. Leroux himself was in my district, actually, in Mqanduli in Tulele Hospital. I salute you, sir. My aunt has been a nurse in the public health system in rural areas specifically for an uninterrupted 45 years. And as a worker, I know how challenging things are for her and her colleagues. The two biggest obstacles we faced were obligation to provide meaningful right to health care, including reproductive health, access and quality. In some cases, both are missing, but often either access or quality are deficient. How do we begin to ensure access to quality health care when the most populous province, Gauteng, not a single one of the 34 provincial hospitals comply with occupational health and safety standards? Looking broadly, Chair, the Office of Health Standards Compliance has only inspected 4% of the country's 51,000 healthcare facilities, with less than 40% of these meeting OHSC standards. Minister, these numbers point to a healthcare system that is in a critical condition and at a high risk. These are not just numbers, but these are people that go to these facilities. We need to wake up and start delivering healthcare that does exactly that. RIZ-ZANSI expects a responsive budget to account for new and worsening public health threats such as addiction to drugs, alcohol, and gambling. These are destroying families and communities, especially young people who have to deal with the crushing burden of unemployment. RIZ-ZANSI welcomes the funding for the employment of unemployed doctors and nurses and efforts to raise funds to close the gap left by PEPFAR assistance. Minister, this budget needs to do more, including employing competent administrators, rooting out procurement corruption, prioritizing efficient delivery of equipment and medication, digitization, improving the working conditions of healthcare workers. Minister, effective management and leadership matter. I know numerous nurses, doctors, and other healthcare workers who work for managers who are incompetent, arrogant, and uncaring, driving the cycle of abuse in the system, which ends up on the shoulders of patients. Expanding the training of additional healthcare workers to keep up with both population expansion and urbanization is absolutely essential. This speaks to getting accurate information from states for whom we have continued to motivate for more funding. We will support this budget vote. Thank you.
Thank you, Honourable Member. We invite the Honourable Maimane.
Hey. Wawona, in last year, Minister and Deputy Minister, our portfolio committee took time and went to Tambo Memorial Hospital in Gauteng. When you arrive in Tambo Memorial Hospital, it tells a story. It tells a story of what this health budget is effectively all about. It points to certain areas where you find excellence if you go to their casualty. It goes to certain areas where you discover that there were some beds that were short because of the complication of South Africans and non-South Africans. It speaks to a story where when you go to the records department, these records are still not digitized, which means anyone who leaves Tambo Memorial Hospital to go to another hospital, that detail is not available. It speaks to a municipality in Ekurhuleni that is failing, and so as a result of that, the hospital was without water, electricity for some of the time. So when we discuss this budget and we discuss the ecosystem of healthcare, I think, honorable members, we need to work hard at making sure that every rand that is allocated here is spent wisely. It's no use having us a debate about NHI. The Director General in our meeting has already indicated that if we are to fund NHI, it needs to be the highest expenditure item on our budget, higher than debt servicing cost. And therefore, to speak about it here is in fact fallacious. It is clear that we need to increase funding towards healthcare, or we're going to live with doctor-patient ratios of 1 to 3,000, as is the case right now. Or we're going to live with nurses that are sitting at about 1 for every 218 patients. So, Minister, whether you go to Baragwanath, Charlotte Maxeke, I want to endorse what Dr. Letlape says. Of course, where I'm in an accident, I want to go to Baragwanath Hospital because there the specialists are there. But we've got to look after them and we've got to make sure they stay in the country. And therefore, as part of the proposals I want to put forward, if we're going to ensure this budget goes far, is that we need to think about the future of healthcare in this country. We certainly can't be heading towards America where litigation is the order of the day, because what provincial budgets are being spent on is really on medical legal claims, settling last year's debts and trying to deal with this year's budgets. The second issue is that we've got to prioritize digital integration. You must have a digital ID as a South African so that it is easier for us to transfer health data from one place to another. We have to invest where the burden of disease is greatest. We have to treat rural hospitals the same as we do urban ones. We have to root out corruption. We cannot sit here and listen to people in Tembisa and all the issues that have gone on there when whistleblowers are being killed. That is a serious blow to our healthcare. And ultimately, let's build a healthcare system that evolves over time and is consistent with the world. And therefore, Honorable Minister, I support this budget and want to state categorically that it is now time to take deliberate action on healthcare. Enkosi, siyabule.
Thank you, Honorable Member. We invite the Honorable Zungula.
Thank you. Would like to take this moment to honor the life of Dr. Alulu Tomazwi, an intern in Prince Msheni Memorial Hospital who died working under extremely harsh conditions and under an uncaring supervisor. What is happening in the health sector must be characterized as a crisis. Hospitals and clinics have got a shortage of essential drugs, nurses, and doctors. There is overcrowding, and the department must engage Home Affairs to deal with this crisis. It is even more concerning that in some areas, there are syndicates who go to the hospitals to get medicine for the purpose of trafficking to other countries. The shortage of beds is a critical issue as women are forced to sleep on the floor as they give beds to women who are active in labor. Decisive action, Minister, must be taken against the medical aid schemes that were found to racially discriminate black healthcare providers. We plead with you, Minister, engage Treasury to get the money needed to fund the employment of doctors. It is not human for a doctor to work for 36 hours. Their mental health needs to be considered as well. We must consider the lives of the patients, as there's a big difference in care for a patient seen at the first hour versus the last hour of a call, as functionality will definitely be impaired. The department needs to deal with the bogus doctors that operate in some communities. These bogus doctors are risking the lives of poor citizens who desperately need help. Minister, build state capacity, even with ARVs. We can't be importing ARVs, yet we've got the capacity to produce ARVs locally. On the tobacco bill, the approach needs to make sense. Having an approach that says all harm is harm, it is not evidence-based, nor is it scientific. The bill seems to be developed in the USA with no appreciation of the local context in terms of illicit tobacco trade and socio-economic conditions facing the country. Minister, we are not a colony of the USA. We can't be in support of a health policy directive that is not informed by the people of this country. Even worse when you've got foreign-funded NGOs that lead the government process in advancing the bill at NEDLEC. It's even more concerning that the very same NGO was found in some countries to be improperly influencing government policy. Yet, in South Africa, the very same NGO is given lead to direct the government policy on tobacco. The policy on tobacco must be informed by the people of this country. It must not be imposed by foreign-funded NGOs, because those foreign-funded NGOs are advancing their narrow interests. They'll never advance the interests of South African citizens. We reject this bill. Thank you.
Thank you, honourable members. Honourable members, I've been alerted, order members, I've been alerted of photographers that are not sanctioned to take pictures. Accordingly, the rules that govern the mini plenaries requires of all photographers who will be taking to be on official basis, meaning they are properly accredited. And members of the public who are taking pictures should not be doing so. They are in the house, so honorable members, that is for those that are taking pictures without being properly accredited. We continue, the support staff will assist the member of the public doing so to exit the mini plenary. Honorable members, we now invite the honorable clerk .
Good afternoon, Chairperson and all colleagues. South Africa is in the grip of deepening healthcare crisis. And one only has to look at the department's mismatched priorities, inefficient spending, and deeply entrenched systemic failures to see the cause. While the slight increase of 1.7% from 63.7 billion to 64.8 billion is welcomed, the modest growth fails to reflect the scale of South Africa's healthcare crisis. Crumbling and dangerous infrastructure, critical vacancies remain unfilled, and patients dying in waiting rooms. Of major concern is that 93% of this budget is allocated through conditional grants, which still suffer from weak oversight and inconsistent provincial delivery. Not to mention the department's chronic underspending. In 2023-24, the department underspent by 3%, and the administration program alone underspent by 15%. This is unacceptable when public hospitals are crumbling and there are massive shortages of nurses, doctors, equipment, and medicine, and when patients wait months, even years for treatment. Every unspent rand is a lost opportunity to save lives. We welcome the 6.7 billion provisional allocation for the hiring of doctors, absorbing community healthcare workers, and addressing hospital supply shortages, as well as the committee's insistence that the allocation must be ring-fenced for this purpose. We need to ensure that the money is spent as intended, to ensure that trained professionals, many from top universities, do not sit idle. In KwaZulu-Natal, unemployed doctors went as far as to set up makeshift clinics outside healthcare offices to protest their unemployment, given the vast shortages of medical personnel. Given the department's anxiety regarding its unmanageable vacancy rates, inconsistencies in claim regarding the numbers of medical officials hired cannot be tolerated. South Africa is not in the financial position to carry the enormous cost burden of the NHI in its current form, which is why we recommend that all bureaucratic bloat and advertising be cut from the NHI budget and that the money be used to improve actual healthcare services by employing critical medical staff, infrastructure upgrades, and effective partnerships with the private sector. 155 children died in public hospitals with acute malnutrition as the underlying cause in the first 4 months of this year alone. In the same period, 4,759 children were admitted. The 28 million rand spent on NHI advertising would have made a marked impact on these young lives. How many community health workers could have been employed with that funding? Then there's the entities. The National Health Laboratory Service is making good progress, but the Office of the Health Standard Compliance met only 21% of its inspection targets. We cannot hope to improve the quality of public health care if the OHSC isn't enabled to inspect more healthcare facilities and enforce compliance. Much closer monitoring of conditional grants such as the District Health Programme and the HIV/AIDS Programme is needed, especially in the light of the lost PEPFAR funding. And Minister, I look forward to Friday's committee meeting where we unpack the additional funding that we are going to be receiving from Treasury. I think that is welcomed, and I look forward to see how that funding is going to be placed. The development of a national electronic health record system enabling real-time tracking of patients, providers, and outcomes must be fast-tracked to reduce waste, fight fraud, and ensure accountability. Speaking of accountability, when is the department implementing Treasury and the Department of Public Service and Administration's employee audit to root out so-called ghost employees? The committee has raised critical questions that remain unanswered. Why are 21% of people living with HIV still not on ARVs? How will the department address the mental health neglect and the debt crisis in the Eastern Cape and Gauteng, where some health departments may soon need administration? What is the plan to respond to the cancer treatment crisis? Why do none of the Gauteng's 37 hospitals comply with the OHS Act? Even as the department boasts an unqualified audit opinion, financial discipline and healthcare governance remains dangerously inadequate. Infrastructure remains decayed, key posts remain vacant, and data reporting, especially from regulators like SAPRA, remains patchy at best. No society can grow economically without a functioning public health system. Every clinic that fails, every ambulance that does not arrive, every medicine stockout is another barrier to jobs, education, productivity, and growth. Healthcare is the bedrock of human dignity and national development. The lived reality of millions of South Africans is an indictment on this department. The DA will not be silent. We will demand answers and we will monitor every rand. We will fight for a public health system that delivers dignity, care and hope to every South Africa, rich or poor, rural or urban, public or private.
Member,
I thank you.
Your time has expired. Honorable Dr. Lomo, it's your opportunity to speak.
Chair, Minister Mtsoaledi, Deputy Minister Phahla, I have done 120 park runs, Deputy Minister. Distinguished guests, honorable members, happy birthday to our Honorable Sine, the last born of the ANC team here. The signing of the NHI Act by President Ramaphosa in May last year marked a defining moment in realizing a long-cherished vision of the African National Congress, which dates back as far as 1943 through the African claims, where our forebears envisioned a just and equitable system that caters to all without discrimination. That vision found resonance in 1955 when the Congress of the People in Kliptown adopted the Freedom Charter, which boldly declared a prenatal health system, which my deputy minister has spoken very well on. This is an illustration that the concept of the NHI is not new. The signing of an NHI into law represented the long-awaited restoration of a vision for a united and healthier South Africa. The NHI Act embodies the dreams of our forebears. It is an intergenerational mandate that has been carried forward for centuries now, over 70 years, finally declaring in a legislative form. As we celebrate the 70 years of anniversary of Freedom Charter, we are reminded how its essence has shaped our democratic dispensation through fundamental clauses which declare that all national groups, not just some, but all, shall have equal rights. All shall enjoy equal human rights. These values are the bedrock on which our Constitution was founded, which culminated in the Bill of Rights and Section 27 of the Constitution, which declares that everyone has the right to have access to healthcare services. Therefore, it is both moral and legally responsible of the state not to discriminate in the provision of healthcare, but to ensure that all in need are treated with dignity and care. This is also aligned with our African identity as captured in the spirit of Ubuntu, which teaches us to treat the next person with respect. Umuntu ngumuntu ngabantu. As the African National Congress, this is what has informed our conceptualization and approach to the NHI and our aspirations for universal health coverage. In keeping with the Presidential Health Compact, Minister, high quality and compliant infrastructure is an integral part of transforming our healthcare system. We therefore welcome the allocation of 7.2 billion to the health facilities revitalization grants, as well as the combined 3 billion earmarked for Limpopo Central Hospital, Central Academic Hospital, and Siloam District Hospital. Listening is a skill. There are honorable members who talk about not forgetting that KZN, Western Cape, and Gauteng were the only provinces that had central hospitals. Now, this government is decentralizing and making sure all other provinces now would have specialist care without traveling too much. Our clinics and hospitals must not merely exist, they must be equipped and maintained to the ideal standards. We therefore support the 2025-2026 target of 2,800 primary healthcare facilities achieving the ideal clinic standards, as well as the maintenance, repair, and refurbishments up to 550 public health facilities annually. We commend the work of the Section 59 report, which was led by Advocate Tebeka Gaitobi, on allegations of unfair racial discrimination and procedural unfairness by medical schemes. These findings reveal that black healthcare professionals were more likely to be investigated, found guilty, and penalized by medical aid schemes. In 2022, medical aid schemes collected over 218 billion, where the lion's share of their fund went in the following: 1, private healthcare institutions with a 77 billion rand, private specialists taking 59 billion rand, pharmaceuticals 33 billion rand, 18.9 billion went to what are people not even providing, administrators not even providing any healthcare to anybody. GPs, and in particular black GPs, were followed for possible fraud, wastage, and abuse for only receiving 5.3 billion, only 5.3% of this cake. A situation like this would not have arisen in a country like People's Republic of Cuba, a country that values all human lives and has universal health coverage. The report endorses the correctness of the NHI Act. Minister, the final report of this Section 59 investigation, together with the health market inquiry, must support you against those who are taking the government to court on the NHI Act. Both reports debunk the myth that says, I quote, fix the public health sector and leave the private health sector alone, close quote. As these two reports expose the deep structural and systematic challenges within the private healthcare sector. We are all encouraged, Minister, by the fact that you promptly made yourself available to be briefed as soon as this report was finalized. This is a testament to the responsiveness of the ANC-led government in addressing matters that hinder the transformation of our healthcare system. I also appreciate, Minister, that through our discussions yesterday, you will be available this coming Friday
to actually brief the portfolio committee as to this matter that is actually, it will be very important, probably, Minister, that you consider, accompanied by the Council for Medical Schemes, as some of the Section 59 investigation reports have recommendations that talk to them. Being the largest representative body, SAMA was expected to represent doctors, including black GPs, but became a bystander instead of leading this process that brought this damning report about certain medical aid schemes. The South African medical aid scheme has failed to champion an interest of its members. Honorable members, it will be important to just say, listening is a very important skill that some of us have learned, have not really captured. Minister was talking to some of these issues, but people hardly captured some of them. South Africa must understand that when some political parties reject this budget, it means they are rejecting the payment of salaries of doctors, of nurses, and other healthcare professionals who tirelessly care for our citizens daily. Professionals who actually rely on this income, legally as it may be, are actually not being supported by these political parties, the EFF and the MK party. By rejecting this budget, these political parties will be saying we must not make funds available to address the unemployed doctors and other healthcare professionals. Rejecting this budget means rejecting the procurement of much needed medication, as well as upgrading and construction of healthcare infrastructure that will strengthen the provision of quality and dignity care of our people. To reject this budget is to reject the people of South Africa and the right of them for a better life. As the African National Congress, we stand with South Africans and support this budget towards the realization of a united, quality and equitable healthcare system where no one is left behind. Honorable Measure, I am in discussion with Honorable Swart on these issues of international regulations that you referred to. My discussion with him is different from what you are understanding. So maybe let's include you in those discussions because we will then be able to inform you better. Honorable Van Staden, we welcome your suggestion that when we go to KZN province, we saw the bad and the good. We saw the good and we raised it here, the Pixtika is but we're also not hiding the challenges that are there at Prince Msheni, which Honorable Minister must consider, we must continue to support. Honorable Tetoleru, you just said you want to see any member who will take his relative to a clinic. I don't take my relatives there. I go myself. I use Umbumbulu Clinic, and they refer me to better height facilities if my need is there. So we do that. And like the minister will also tell you. Honorable Chirwa, sometimes a budget like this needs more than just common sense. So it will assist you to do that. Thank you, Honorable Chair.
Order, honorable members. Order, honorable members. Order, honorable members. Order, honorable members. Can we be orderly? The House is still in session. The House is still in session. Can we be orderly? Honorable members, we now invite the Minister, Dr. Aaron Motsoaledi, to respond to the debate.
Thank you very much, House Chair.
Honorable Minister, can you take a seat? Honorable Member, on what rule are you rising on?
Yes, sir. Honorable Chairperson, Minister, on his first speech, he spoke and exceeded his time by 34 minutes. Can the minutes be 4 minutes? Wait,
Member,
can be 4 minutes, 26
member,
seconds. He exceeded his time.
Honorable Member.
Yes.
Honorable Member, in this House and in this plenary, we have the table staff that is responsible for that. It's not your responsibility to tell the House on the time. These are the qualified persons to tell us on the time. Honorable Minister, may you continue.
Thank you, Honorable House Chair. Dr. Letlape, I fully today agree with an approach you have followed here. And I was going to expand more, but unfortunately, I will have to pack it a little bit and come back when there's time. Because there are two people who scared me to my bones. The first person who scared me is Muruti Meshwe. Muruti Awaban. Muruti Hanti Ujirega Wamban. Honestly, you scared me. Because everybody is celebrating this pandemic preparedness. And I know members here might not know what happened. During COVID, rich countries were holding vaccines. Everything that was used to fight COVID was in rich countries. At the end of COVID, the World Health Organization was worried that this is going to happen when another pandemic came. They then said there must be negotiations. A pandemic negotiation committee was set, and coincidentally, they said it must be chaired by France and South Africa. Here we used our former DG, Professor Precious Machos. France used their director of global health. They said they negotiated, it took 3 years. What were they negotiating? How to share the benefits, how to share the need to fight pandemics if another pandemic came. The centrality of that pandemic preparedness is what is called PAPS. PAPS means Pathogen Access and Benefit System, meaning whenever there is a disease, infectious disease, which usually starts in Africa, rich countries come here, take the pathogen, go to study it, manufacture a medicine, and then the people where the pathogen came from get nothing. The Pathogen Access and Benefit proposes that if a country comes to your country to take a pathogen and produce a medicine, you are entitled to the share of what they are going to get. As an international pharmaceutical company, how can Murutu run into a Muhutumara? When we debated this thing in Geneva, there was no secrecy. It was rejected by America. There's no secrecy, it was rejected by America. But they didn't come. Remember, America is boycotting World Health Organization. So what they did, they were moving all over Geneva with buses written, away with the pathogen agreement, away with the... But they were doing it in the streets. We did it in the hall. Out of the 134 countries that were there, nobody rejected this thing. Only 11 abstained. The rest we supported fully. And so why do you say it happened secretly? It was in public. We voted in public. In fact, I've got pictures I'll show you. They said we must not even vote with machines. We're raising country flags. Each country was raising their flag and say, South Africa, I support, this and that I support. So please, Muruti, man, support about man. Yes. The second person wants to change Ndate Zungula. This thing of tobacco and Ndate Zungula, the Framework Convention on Tobacco Control signed in 2003 is the most supported public health treaty in the whole of United Nations. There's never been a treaty that has been signed than the one that supports tobacco control in the world. It was signed by 183 countries under UN. They all signed it and say, this is the way to go. Even our own ally, and I want to tell you this story because I don't have much time, I realize that. When the Minister of Health in Australia introduced this packaging that doesn't have colors, yes, by banning branding, she was taken to court. She won. They appealed against her, she won, and we're supporting her. Cuba, which you know is our ally, is not a secret. When they realized she's winning, they said because they are producing the Havana cigar, they said they are no longer taking the matter to the court, they are taking it to WTO, World Trade Organization. Go through it through trade and say, our right to trade. They asked us to support them. And we said, unfortunately, this case, no. We can't support tobacco. We cannot. The matter went to the World Trade Organization. The ruling was that the World Health Organization and World Trade Organization must sit together. It took 10 years and eventually the World Health Organization won. They said Tobago is not in the interest of people around this world. So please, thank you.
Thank you, honorable members. May I remind the honorable members that time allocation can exceed with the discretion of the chairperson, and that if you have anything against that, you will have to write to the speaker and submit to the rules committee. So the fact that you are not behind this chair does not give you the right to say the chairperson must not give allocation in terms of the seconds. That in itself, honorable members.
Opposite, yes. No.
Members,
we need to oppose
order.
whatever you do.
Order.
Thank you.
Honorable members, those gestures on their own says that you are out of order. Your rules, the rules of the House that you have agreed upon, which are the 9th editions, prohibits you from also doing that. Honorable members, may I remind honorable members that simultaneously there are 2 debates that are taking place in this parliament at 16:30. That is the water and sanitation budget debate and the debate on the Chief Justice and constitutional budget. That, honorable members, concludes the debate and the mini plenary may rise.